Good afternoon and welcome to the fourth session of the Brain Injury Association's 20th Annual Conference Series. My name is Doreen Grasso, and I'm the Education and Program Manager here at BRI. We're delighted that you can join us today for COVID-19 Neurocognitive and Psychological Effects. Before we get started, here is our Executive Director, Deborah Sharp, with a few words.
Good afternoon, and thank you for joining us. I am Deborah Sharp, the Executive Director of the Brain Injury Association of Rhode Island, and I want to thank you for being here in support of our new conference series. As Doreen said, this year's the 20th anniversary of hosting conferences focused on improving knowledge of and awareness about brain injury and the impact of brain injury on our society. Like many organizations, the COVID pandemic forced changes to our conference structure. Normally, our conference is a full-day in-person conference, but given the world that we've been living in, we had to make some changes. And so this year, we decided to host a 6-series educational conference so that over the next several months, there will be various current and relevant topics available for you. We have 2 conference webinars following this one today. So this new approach actually allows us to engage people all over the country, and it's been really exciting for us. So be sure to check out our website, which is biari.org, so that you can explore this year's conference series, the 2 remaining webinars, which are running through October, and the other ways that BIARI accomplishes its mission of increasing awareness and educating people to prevent brain injury. So our goal is to enhance the quality of life for everyone affected by brain injury, and this conference series is one way that we help increase knowledge and awareness of brain injury moving forward. So thank you for joining us. I know you're going to enjoy this. It sounds like a really interesting topic to me. And I'd like to just begin by thanking our sponsors, without whom we wouldn't be able to continue our mission. So thank you to Evanly Organics, to Morosco and Nesselbush, and especially to our platinum sponsor, Encompass Health. And now it's my pleasure to introduce to you Daniel Parkinson. Dan is the Business Development Manager at Encompass Health, and he's here to just share a few words with us. So thank you. Enjoy the conference. Dan?
Hello, my name is Dan Parkinson, and I work at Encompass Health Rehabilitation Hospital in Braintree, also known as Braintree Rehab. We're an inpatient acute rehabilitation hospital, and we've earned the disease-specific certifications in both brain injury and stroke rehab from the Joint Commission. This means that we have a programmatic approach to our delivery of care that allows us to realize the strongest patient outcomes. The essential components of our program consist of using evidence-based, consensus-driven clinical practice guidelines to drive our interventions and our assessments. We have a multidisciplinary team that's led by Dr. Katz, a neurologist, and our team consists of physical therapists, occupational therapists, speech therapists, nurses who are certified in rehabilitation, and case managers. We implement performance improvement measures that are related to our clinical practice guidelines to help us drive our patient outcomes. We analyze our patient outcomes by both trending our own data over time and by comparing our data to other rehab hospitals both in the region and throughout the country. I really want to take this opportunity to thank the Rhode Island Brain Injury Association for hosting this incredible virtual learning experience and for giving us here at Encompass Health Rehabilitation Hospital of Braintree the opportunity to introduce ourselves. Thank you and enjoy the educational opportunity.
Thank you, Dan. Before we start with our presentation, there is a couple of housekeeping notes that I'd like to make. There's a survey to complete with this webinar. Your feedback is very important to us. And it's also your ticket to your CEUs should you be getting those. So the survey will show up in two places. So you have two choices. It'll be showing up on your browser at the end of this webinar through Zoom. It'll also be part of your follow-up email. So either way, just make sure that you fill that out completely and get it back to us. And we should be giving you your CEU certificates in about a week after, within a week. People who join for the whole series will get it in October at the end of the series. So that's pretty easy there. Lastly, all the questions, if you want, we're gonna have a little Q&A at the end. If you can type your questions in the chat box, we will be going that at the end with Dr. Horn. And I'd like to introduce the speaker for today's session, Dr. Horn. And Dr. Horn, oh, there you go. Dr. Horn serves as one of the National Directors of Analytics and Clinical Outcomes for Neurorestorative and is co-chair of Neurorestorative Research Institute. Before working in national outcomes, he was the clinical state director for Neurorestorative Florida. Prior to Neurorestorative, he was the director of programs and clinical services for an independent post-hospital rehabilitation company overseeing multiple programs in Florida and Michigan. Dr. Horn has been a licensed neuropsychologist since 1996, providing care across acute neurological continuum, including neurotrauma, neurologic ICU, and critical care behavioral management, hospital neuroscience programming, inpatient and outpatient neurorehabilitation, post-hospital neurorehabilitation for neurologically injured. So without further ado, I'd like to welcome Dr. Horn.
Great, thank you, Doreen, I appreciate it. Good afternoon, everybody, and hope everything is good in Rhode Island. So I was telling folks a little bit earlier, I'm calling from the Central Florida area where it's 90 degrees and about 100% humidity because it's summertime. So let's talk a little bit, and I'm gonna go ahead and share my screen, and that way we can actually all see this together. So today we're going to talk about really the effects of COVID, and we're going to talk about really two particular things. One is we want to talk specifically about the neurologic features of COVID. And in addition to that, we're going to talk about the psychological features as well. Hopefully you'll learn and understand about the recovery process and complications that actually can occur. And participants will also learn about uncontrolled stress associated with the COVID pandemic and how this parallels the chronicity of traumatic brain injury. And then finally, we're going to talk about stress management techniques because certainly everybody can use stress management techniques, and it's also a great thing to do on a Friday afternoon. So let me kind of tell you just a couple of basic things here first, and then I'm going to give you some updated statistics. One of the things I want you to keep aware of is this. When I actually first really dove into the research for putting this lecture together, it actually was back in September of 2020. And what has happened is about once a month, there have been updates that have been happening. So even though this lecture was written a while back, I'm going to try to give you updates so that way you can know what's going on. One of the reasons why the updates have been happening is because COVID has been new to everybody. And so to give you an example, the first set of research that actually was coming out on the effects of COVID happened about 6 months after the spread of the pandemic. And then about every month thereafter, then we've been having more and more data that's been coming in. Very clearly, we do not know everything about COVID, and we certainly don't know about the long-term effects of COVID at this point because nobody has been surveyed long-term because, again, this is still relatively new. Some of that data really is not going to come out until probably about 5 years from now. So just kind of keep that in mind. We are going to talk about the current rate of COVID infection. And as you know, in the United States, our rate of infection is actually going down. And what's happening, of course, is in different states, it's happening in different ways. So to give you an example, we have about 3.7 million people overall that have actually died from the effects of COVID. We've had a total of 172 million who have been affected by COVID or have been infected by COVID. And this is a pretty significant statistic because this will really kind of blow your mind a little bit. There have been 2 trillion doses of COVID vaccine that have been given around the world. So that's an astounding number when you actually think about it. Now, in the United States alone, we're looking at about 60% of the adult population has now been essentially has now gotten the vaccination and if you had the one that had 2 vaccinations, either the Pfizer or the Moderna, again, all of this is inclusive, but we have about 60% of adults who've now been vaccinated. Here's the tough part that we're still trying to struggle with, and that is this. The statistic that actually came out this morning is that only about 9% of our kids have actually been vaccinated at this time. Now, of course, there's many reasons for that. One of the main reasons is, of course, is that kids kind of came later in terms of approving for vaccination. And as time has gone on, we're seeing that you can go lower and lower in terms of age group. But that's something that's really important because over the course of the summertime, of course, we're going to be getting ready for the school season in the fall, and it's going to be important that our kids get protected. The other thing that was really interesting was this, is that those who have been infected, those kids who have been infected, they were talking this morning that approximately 25% of the kids who were infected actually did require hospitalization, and in most cases required some level of mechanical ventilation. So this is something very much to take seriously, in that it's not just an adult disease. It's a disease that can really affect anybody at any time for any reason, meaning that it is not a socioeconomic issue. It is not an adult versus a kid issue. It is a exposure issue is what it really comes down to. So these are just some basic statistics to think about. This statistic I always like to kind of talk about, and that is in the medical world. So the pandemic has led to many medical complications ranging from very mild symptoms to death, and has raised the issue of living in isolation and fear. Up to 73% of healthcare workers reported post-traumatic stress symptoms during outbreaks, with symptoms lasting as long as 1 to 3 years, and upwards of 40% of those who had been sampled. Now remember, keep this in mind, this isn't just COVID specific. This is looking at any pandemic that has occurred and then really evaluating healthcare workers in particular. We all know that when we're on the front lines of healthcare, that we have particular risks. So for example, as you heard in kind of my bio, I've been very hospital-based for much of my career, and I've been in the post-acute world now for almost 12 years. And that combining the post-acute world with 20 years of hospital work, you'd be surprised at what the overall health risk is. And most healthcare workers just don't really think about that risk. You go to work every day, you do your thing, but we're used to taking precautions. And so it also means that healthcare workers can sometimes live in isolation because they sometimes feel that people may not really understand what they're up against on a day-to-day basis. I can tell you back in the 1980s when we had the HIV and AIDS crisis, this was when I was early in my career, and what was happening, of course, at that time is everyone was afraid of being exposed to HIV and AIDS. And, you know, it turned out roughly 10 years later that it was easier to catch hepatitis in the hospital than it was to actually be exposed to AIDS or HIV. So I think we're going to learn a lot more about this, but just keep this in mind, is that different subsets of the population are really affected by this in very different ways. However, we're going to talk about some common pathways for all of us to kind of take away from this. You know, this is something that I always like to kind of ask, and even though we are coming on, you know, on the back end of this pandemic in the sense of the acuity, please don't think that the pandemic is over by any means. It's not. It's a virus. And so just like all viruses, is that viruses behave based on how they come and go, and then how they jump from host to host, and then how they morph or change in terms of their own code. So here's the question, are you okay? So what we currently know is this, is that taking one's temperature is actually a good predictor. So remember that just because things are getting better, it doesn't mean that you are without risk of still being exposed to COVID, and that you could still be testing positive for COVID. But taking one's temperature does seem to be something that helps to assess those early symptoms. And the early symptoms would be this, is that it's typically a temperature of 99 to about 101. And that is a common temperature for viruses. That's actually one of the ways of how you know that it's a virus and not a bacterial infection. Bacterial infections have a tendency to rise much higher. We know that wearing a mask does in fact work. So even though precautions are being lessened, it may still be a good idea that when you travel, that you still wear a mask because of close proximity to people. We know that minimizing exposure also makes a difference. And we know that there's a 6-foot distance rule that's now being modified to 3-foot distance. But think about who it is that you're around or that you're with. And if you feel uncomfortable, then take that precaution or move yourself into a direction where maybe you don't have as great of exposure. Things like the incubation period, we know this. In the CDC guidelines, we know that essentially that the first 2 days is where the virus, if it's going to then contact that host, that's where you then may begin to show the earliest of symptoms. But we know that the overall incubation is from basically day 1 of exposure through day 9. And what we know is that that is when you're at the highest risk of them being infectious to other people. Also keep this in mind, and this I thought was an astounding statistic, and it came out about 9 months ago, which was this. For every one person that gets infected, they actually have the capacity of then infecting 50 other people. So it's a 1 to 50 ratio, and that is an astounding ratio. That's also one of the reasons why it spreads so fast and spread across the world, also because we travel across the world. We don't stay within one country and one location. So just keep the incubation period in mind. Also know that if someone becomes exposed or someone is showing symptoms of COVID, obviously you want to do whatever you can do for comfort measures, but also you want to really think about how to help the person if it's in your own home. I'll give you a quick aside, is that my wife and I both have been vaccinated a number of months ago, and because I have many healthcare connections, then I too was vaccinated very early, but my son was not. My son's in college. My son was almost through this entire year, and then he got exposed by, he plays, or he's a rower, and he was exposed by another rower who was not following precautions throughout this entire time, wound up testing positive. He then infected 4 other people in an instant, and my son happened to be one of them. So of course, when we found out, we brought him home, and then we set up our own isolation system in our house. And because my wife and I were already vaccinated, then we took the same standard precautions, but my son within about 10 days then turned right around. But he had many of the symptoms that I'm going to talk about today. Again, these dates and these percentages, continue to change over time. Keep in mind that this was back in September of 2020 when this was first put together, but now it's been updated. I think probably the most important thing to really kind of hone in on is this, is that we had, a large number of fatalities, obviously 3.7 million. In particular, you have to think about the United States in terms of its population. The US accounts for approximately 4.25% of the world's population, but they're ranked 3rd in terms of population size when you're looking per capita. So one of the reasons why our system spread so quickly is because we have multiple points of entry into the country. And then because of the density of our population, remember that we're sitting right now at about 353 million people within the proper United States. Well, that's a very dense population when you consider what happens in the rest of the world. And so because of that, then we became particularly vulnerable to the spread of this disease. And of course, our borders with Mexico and Canada also became very vulnerable as well. And very quickly, you learn by a pandemic that, you know what? We all live in this world together. That just because you live in the United States does not mean you can ignore everybody else in the world, and vice versa. So I think that that's probably the most important thing to keep in mind, is that we account for a very large portion of the population. And in its heyday in September of 2020, the United States was actually accounting for 22% of all confirmed cases, yet only accounted for 4.2% of the population. Now, also in September 2020, we had this strange fluctuation where some states would increase in infection rates, some states were decreasing in infection rates. One of the things that you probably remember from all this is California, and looking at San Francisco and Los Angeles in particular, along with Seattle, Washington. So on the West Coast, they actually were hit first, followed by New York, New York, which was then hit secondly. And I live in a state where it actually was then also a very high rate of infection. But the difference is that our population in Florida is not quite as dense as what you'll get in New York, as what you'll get in Seattle, and what you'll get in San Francisco. And so also those ports tend to be much more international, whereas the ports that are in Florida tend to come more from the islands, Central America, South America, as opposed to coming from all parts of Asia and Europe. So it's really been interesting to watch how this pandemic has shifted and changed. What we also then saw was once the border states were beginning to then show their upward trend, then you notice that it actually then moved across the United States. And it wasn't until later that you saw the Midwest and the upper Midwest all of a sudden begin to blossom with the pandemic rate. And then as that was happening, then the difference between winter versus summer then was causing the states to then shift again. So it was a very dynamic kind of a virus, and it continues to be dynamic. However, we're now into the summer months, and the summer months we tend to see lower infection rates in general for viruses. For clinical symptoms, there's really the acute symptoms versus chronic. The acute symptoms are just like what you would get with the flu. And if you've actually been vaccinated, then you'll appreciate all of these symptoms. When I was vaccinated, I pretty much had all of these symptoms. Fever, cough, sore throat, headache, fatigue, myalgia, breathlessness, conjunctivitis. Chronic symptoms, this is where it becomes more dangerous. This is where we have the potential for pneumonia, respiratory failure, or what's called SARS, which is severe acute respiratory syndrome. As a result of things like SARS and respiratory failure, well, guess what? You can also then have secondary neurologic conditions, one of which is hypoxia or anoxia, which means loss of oxygen to the brain. So remember, folks, that when our brain and our lungs have to work together, the lungs are feeding the brain oxygen. And if the lungs are compromised, guess what? Brain gets compromised as well. Some of the other symptoms that the CDC was really focused in on was, again, fever, chills, cough, fatigue. And what I really want to focus here on is the loss of taste and smell. And the reason why you want to focus in on that and headache is these are neurologic signs. When my son actually contracted the virus, by day 6, he actually lost his taste and smell. He didn't realize it until we were eating lunch, and then he realized that what he was eating, he couldn't even identify because he couldn't taste it and he certainly couldn't smell it. His loss of taste and smell lasted approximately 3 days, and then it spontaneously remitted. So it's one of those things that you hope that if a person is healthy otherwise, that it will come and it will go. When persons have other medical conditions, that's where this becomes even more dangerous, as an example. Emergency signs are things like trouble breathing, confusion, disorientation, inability to stay awake, or if you see a bluishness in the lips, it means that essentially you're starting to crash from a respiratory problem. And in which case, these are not things that you take for granted, and 911 should be called, or you should be taken to the emergency room right away. Less common symptoms, let's talk about that for a second. GI symptoms or gastrointestinal symptoms and inflammation. In the elderly, we were seeing a lot of alterations in mental status, and we were also seeing difficulties with managing blood sugar. The fatigue and myalgias are also things that tend to be very, very common, and these are things that were really being seen across the board. When it came to medical complications, and again, what I'm doing is I'm kind of leading you down the path so that we can then talk about the neurology of this, but you have to understand our body works as a system. So there is no one system that just works in isolation. On the pulmonary disease side, what we learned was this: there's a pro-inflammatory cytokine release that causes pulmonary damage. So there's this condition called cytokine storm. And what it really means is this: it means that your cells go through this massive shift. And what happens is the cells become very dysfunctional. And when they become very dysfunctional, then it causes whatever the organ system is that the virus is primarily contained in to then cause it to not work correctly. And then what that does is it causes then this rippling effect into other organ systems. So for example, At first, we knew that this was a pulmonary issue, but then what we learned is that, well, in addition to lung lesions, what we learned is that the liver can be affected, the kidneys can be affected, the heart can be affected, and certainly the brain can be affected. So those are your major organ systems. And so what happened is that this virus then was not something that was easily contained within the body, and it did not just simply settle in on one organ system. And that's what made this so dangerous and so unpredictable at first. That's also why people had such a variety of symptoms that they didn't really know if they had COVID or not. Now, here's the interesting thing about the neurology. So I have 3 scans on your slides here. So let's start in the middle where it says normal or brain MRI. And this is what a healthy brain actually looks like. This is just a brain MRI. There's no contrast. And this is just simply looking at the tissue. And what you'll see is this very nice differentiation of lighter material and darker material. You can see all the structures and everything looks pretty healthy, pretty normal. And the brain is nice and compact. Now, let's go to the left where it says letter A. So this is where COVID actually had occurred in this particular person. And when they scanned the brain, what they found is that the person actually had 2 hemorrhages that occurred in the brain that was directly related to COVID. Now, there's a couple of reasons for this. The first is that in this particular area, these were hemorrhages that were within what's called the temporal thalamic region. Now, why that's important is this. This is an area that's in the deep structure of the brain, and it controls 2 basic things. One is it controls very high level processing, which is the thalamic region. And every piece of information that the brain has to process has to go through the thalamus. And it either goes up into other areas or it goes down and eventually reaches into the spinal cord. The second is that the temporal lobe was involved. And the temporal lobe we know is involved with memory. So it's not only new learning and new memory, but it's also consolidation of information. And so if these 2 structures are not working properly, then you're going to have pretty significant brain dysfunction. So in this particular case, the COVID was actually leading towards this hemorrhaging effect, and it was a spontaneous effect. And more than likely, it was caused from a combination of blood pressure changes, in addition to causing the cytokine storm, which then caused the cells to dysfunction, which then eventually led to a hemorrhagic stroke. On the right side, you're going to see what's called a cytokine storm. And you'll notice that it looks very like cloudy. And it not only looks cloudy, but it has these pieces that look more bright white. They're kind of within that cloud. So if you can see those arrows are indicating where this is. And this is also in one of the main structures. This is in the deep white matter. And it's sitting just below what are called the ventricles. So it's actually affecting into the midbrain, and it actually can have an effect into the spine. And what's happening here is that the immune system is getting jacked up. And so this particular storm, what the MRI was actually able to show was how dysfunctional the cells had become. And through their dysfunction, it caused the contrast to be able to pick it up as being an acute process. So it was really quite an interesting finding when you actually look at this on MRI. Now, a couple of things that we know from neurologic complications of COVID. The first is that approximately 24.8%, or if you round up, 25% of those who experience COVID, they're going to experience things like headaches and dizziness, impaired consciousness, ataxia, which is a movement disorder, acute stroke, which I had just shown you, or even potentially seizure. Because of course, when the brain is looking like it did in those pictures, then the brain's not going to respond very well. And seizure is one of those things that indicates agitation for the tissue. In addition to that, about 9% of persons experience what are called peripheral nervous system deficits. And this is things like hypogeusia, which is a reduced ability to taste things. Complete lack of taste is referred to ageusia. Hyposmia, which is reduced or loss of smell. Neuralgia, which is an intense and intermittent pain along a nerve fiber or along a nerve track. If any of you had gotten vaccinated who are on the call, if you recall feeling this achiness that you may have experienced as part of the vaccination, That's what was happening, is this neuralgia was being triggered by the fact of causing the protein to activate the immune system to then target COVID. So it has a very similar response to actually having COVID. The difference is you're not being exposed to the virus. And then about 10% experience skeletal muscle symptoms. And so you can see that there's quite a variety here. And remember, this was the early data. So we're actually beginning to now see more. Mental status changes were also being identified. Mental status changes can come from not only a direct effect or a hit to the head, meaning that the stroke or the cytokine storm, or it could be an indirect effect where a person has respiratory failure. They then lose oxygenation, leading to anoxia or hypoxia, and in which case then the person becomes very mentally confused and mentally challenged. If a person also has things like hypertension, diabetes that may or may not be controlled, then you're more likely to have cognitive symptoms simply because these conditions also have a direct effect to the brain. We also saw that about 22% of those who experienced delirium, which is essentially a mental status change, actually wound up dying. So in the very early stages of COVID, if a person all of a sudden had significantly altered mental status changes, then we knew that this was then a much more acute process, and in which case then this is really not good. And now you're into just pure emergency medicine at that point. Two other issues that sometimes will occur. One is encephalopathy, which actually is very similar to delirium. The difference is encephalopathy implies that we don't know exactly the reason for the changes, and it causes a generalized impairment. Encephalitis is an inflammatory process. Anything that ends in itis is always an inflammation of some sort. And this means an inflammation to the brain or to the brain tissue. And just like I had shown you in the cytokine storm, that would be an example of an encephalitis, where the brain tissue becomes so agitated and irritated because of whatever the underlying disease is. And in this particular case, it was COVID. Now, cognitive impairments include things like memory disorders. It includes things like attention, processing. It includes things like decision making. One of the things that was shown is that the production of cerebral actors often lead to neuroinflammation, as well as beta amyloid production, which is more common or typical in Alzheimer's. So as you may have noticed in that cytokine storm, is that when you're activating the brain in this way, that the activity doesn't necessarily stay confined to one small location. Instead, it can be generalized out. From a neuropsychological perspective, what we see is that we see three different areas of impairment. We see central impairment, which is things like your headaches, dizziness, impaired consciousness. And then we see peripheral deficits, which is more of the potentially loss of taste and smell, although that can also be neurologic. And then you may see the musculoskeletal, or you may see the joint issues, pain. So when we think about it from a neuropsychological perspective, we think about it in really kind of those three different ways. Let's talk a little bit about vulnerability. Individuals with an underlying neurologic disease may actually be more vulnerable to neurologic manifestations of COVID via the exacerbation of typical stress response mechanisms. That's a nice mouthful that basically means this. If you've had neurologic injury, neurologic disease, or impairment, the research on the early side was showing that you may actually have a bigger vulnerability to the effect of COVID. Just like if you have diabetes, just like if you have kidney disease, and so on and so forth. So in other words, having a prior disease process can and does in fact make you much more prone to then having problems. So for example, some of the patients of mine would commonly ask during this past year, well, if I've had this brain injury, does that make me more problematic? Like, what do I need to do? And I'd say, well, yes, it makes you more vulnerable, so you have to take extra precaution. Meaning if you really don't need to be out, then don't. Instead, let's wait until people become vaccinated. Also, it is important that when you have an underlying health mechanism or health issue, to talk with your family doctor or talk with your specialist to make sure that you are a good person to then take basically the vaccine. With respect to the coronavirus in general, there's a relationship between corona infection and central nervous system damage, status epilepticus or epilepsy, the development of multiple sclerosis, because multiple sclerosis is an inflammatory process within the brain and spine. It also is associated with a brain injury that's associated with other inflammatory processes. And again, that can include hemorrhage, like what I had shown you before. We talked about febrile seizures, which basically is a seizure that is triggered when your temperature then elevates. And then we also have what's called multifocal leukoencephalopathy. That's a great mouthful, but basically means all your chemistry is all over the place. And what's happening is it's causing you to be very confused. Cognitive vulnerability, just like in any condition, there's always cognitive risks. And as you can imagine, if we go back to the MRIs, you can imagine that the persons that were identified in those MRIs did in fact have cognitive impairments. We know that you can have impairments in attention and concentration, processing, memory, language skills, visual perception, executive functions, and even personality. We know that neurologic conditions that tend to be chronic, and so for example, so those of you who are on this call that are survivors of brain injury, first of all, a shout out to you all. You continue to do what you're doing. But more importantly, this is some of the feedback that I had gotten from patients of mine and also from patients in any of our facilities, which is this. Those who have survived a brain injury longer than 6 months, they've been living with this effect that only the rest of us have gotten to experience because of COVID. And the difference is this: our survivors of brain injuries that are on our call today, you all live with this each and every day. And it's not like in a year from now, it will go away. Whereas the COVID has been something that is hit, and then over time, it's reducing to the point where hopefully it will then no longer be an issue. So for about a year or so, we all, those of us who have not had injury to our brain, we've gotten a chance to experience what it's like for persons who have been injured in terms of understanding social isolation and dealing with the effects of day to day and having a very limited or very restricted social skills or social abilities and having very limited resources to be able to then handle some of those day-to-day activities. And so for that, I hope that all of us have gained a much greater appreciation for those who have survived. And again, a shout out to you all who have survived. Let's talk a little bit more about neuropathology. Neuropathology, what it really means is this: it means chemistry, and it means brain tissue, and it means fluid. So from the brain tissue perspective, we've already spent a lot of time on that, so I'm not going to go through it again. But essentially, this is where you get the inflammatory process or changes in the actual tissue. The chemistry changes as a result of the tissue changing. So if the tissue somehow modifies, then what happens is those cells they don't produce the right chemistry or the right chemical reaction. And in which case, then it leads to more dysfunction. This can affect things like the metabolic rate. So metabolically, when we're dealing with things like blood glucose or sugar, things like salt or sodium, things like potassium, these are key ingredients as to how our cells work. And so if we have cell dysfunction, it will then disrupt things like sodium and potassium doing what they're supposed to do on a day-to-day basis. We also know that in the white matter disease, and actually the scans that I showed you demonstrated this white matter disease, meaning it's more in the deeper structures of the brain, is that it really affects what's called astrocytic activation. Astrocytes are what are called helper cells or support cells. So I want you to think of a neuron as being this very long wire. Well, that wire cannot work in isolation. It has to have help. And the help that it has is astrocytes. And so astrocytes, if my finger is a nerve cell, astrocytes basically surround it. And what those astrocytes do is they constantly clean the area and they get rid of all the garbage, and then they allow good things to come in. And what they do is they keep the integrity of that nerve intact. So again, it's this constant helping. If you've ever seen a bridge that's been repaired, you'll notice that a new bridge, they paint it. And then you'll notice about every 2 years, they'll come back and they repaint it over and over and over. Well, especially in Rhode Island, where you're a coastal state, you have a lot of salt air, and that salt air will then cause decompensation of those bridges. So by continuously repairing and painting, you're then maintaining those bridges so that they can stand for a very long period of time. That's exactly what the astrocytes do. They are the workers that keep it working. And what happens is that these astrocytes get screwed up big time. And when they get screwed up, guess what? Neurons don't work because now you have no helper. So now I want you to think about a bridge that you may have come across maybe in some of the back roads where that bridge looks like, my gosh, if you step on it, it's going to fall apart. Well, that's exactly what's been happening in the brain when those astrocytes are then prevented from doing their job. Is the bridge is that neuron, and that neuron just simply is struggling more and more and more. And that's the idea. Hopefully that gives you kind of an insight into the inside of what the brain is actually going through. Now we're going to talk about treatment real quick. So treatment with neurologic impairment is this. Treatment is designed the same as if it were other neurologic impairments, meaning those who've had major neurocognitive and neurological deficits as a result of COVID or respiratory impairment, then what we do is we actually do the same treatment, which is we treat symptoms. So if there's problems, we also then treat the person by putting them into a comprehensive rehabilitation program. And in fact, there is a program that we use in rehabilitation, especially in neurologic rehabilitation, where we're looking at conditioning factors. Conditioning means this: every day when I get up and I move around and I do all these normal things, that I'm a combination of sitting, standing all day long. And what that's doing is it's building muscle, but more importantly is it helps my lungs to actually work correctly. And so what that does is it then allows me to feed oxygen to my system, and so on and so forth. Well, what happens in acute respiratory response is that a person then becomes deconditioned, because not only do they not take in as much oxygen, but what then happens is your muscles begin to atrophy very fast. And so the rule of thumb is that for every day that you're down or that you're not able to be moving, then it takes 3 days for you to then return back to your baseline before you stopped moving. So you can imagine if somebody is in the ICU for 30 days, well, it's going to be at least 90 days before the person is actually just simply up and able to move without getting winded. It's going to be closer to a year before they actually get to that now what you would hope to be their baseline to be. So again, we have to take that into consideration in the neurologic recovery process. Now, you all know the levels of care, but I'm just going to repeat them real quick. We have the hospital acute care, but for COVID, we also then want to have folks go to inpatient rehab and then go to post-hospital rehab if they're in fact not ready to return home. And then, of course, following up with outpatient and home and community. But the idea is the continuum of care and treatment that we do in brain injury rehabilitation is exactly the same continuum of care that we use with COVID that has brain injury complications. Now, the psychology of things. I don't know about you, but I can tell you that over the course of roughly 12 to 15 months, you start to get a bit antsy. And it's that whole concept of having cabin fever, but for too long. It's one thing to be up in Rhode Island when you're in January and you're wondering how much more snow are we really going to get today. But we know that that's going to go away in another month or 2 or 3. But in COVID, we had no idea what the actual outcome was going to be. And we also had absolutely no idea if you were going to get infected or not. We also know this, and those of you who are survivors and families, we know that neurologic injury and mood are highly intercorrelated. So to give you an example, one of the things that I talk about all the time is there is mood-related disorders that are psychological, meaning it has to do with stress, it has to do with the environment. It has to do with things like getting along with people or having difficulties with whatever may be happening at the time. There's also a neurologically based mood that we know for sure in brain injury, and we also know that that can affect or be affected in COVID-19 as well. This is where the neurology is not working properly. And what happens is it actually increases mood variability and mood destabilization. So for example, one of the things that it will do is it can cause agitation, irritability, and so on and so forth. Well, the social isolation that occurred with COVID-19 was something that was really never experienced by pretty much everybody who is alive today. The social isolation often produces worry, anxiety, and fear that then leads to a feeling of hopelessness and helplessness, which then increases risk of suicide. Hopelessness for change and feeling that one is unable to change their situation are predictors of suicidal ideation. So to answer a question that some of you may have, yes, did suicide, not suicide in particular in terms of completion of suicide, but did suicidal ideation go up? The answer is yes. Did the risk of suicide go up? The answer is yes. And in fact, what we saw was a bit of a delayed response, which is what we predicted in the mental health sector, which was the delay was approximately 4 to 5 months from the onset of when we began to shut down in this country. So we began shutting down basically the end of March of last year. And it was about August is when we started to see really a shift to where anxiety and depression were climbing exponentially at that point in time. And it's because we got through 3 months of absolute uncertainty, and that uncertainty was not going away anytime soon. And as a result of that, the anxiety and depression continued to climb, which meant more and more people were becoming hopeless and helpless. You notice that what people were doing to cope is that they were using video, and they were making funny videos, they were posting things. The idea was to just simply reach out rather than staying within. Significant psychological distress was experienced by hospitalized COVID patients as well. The distress can be in the form of hospital stress and or not knowing if one may live through the experience. Once we started to see people die from COVID, then anybody who was then rushed to the hospital, the very first thought that they had was, oh my gosh, is that it? Am I going to die from this experience? And you can only imagine the distress that places on you. And then they were placing you in the ICU, and then they were placing you in isolation, where the only human contact that you had were doctors and nurses who would come in intermittently but didn't touch you. Instead, they were staying a social distance away. So the isolation became even more profound. Levels of depressive features may be related to inflammation as well, just like what we had talked about. So again, medical and neurologic issues are highly related to mood issues as well. Adhering to social distancing guidelines at the time was also something that was very contradictory to what our normal process really is, and also using hand washing. And so, one of the things that was actually used was, if I can't control the virus, then I can control my behavior. And if I can control my behavior, then I can control things I get exposed to. So I can stop being exposed, but I can also wash my hands, and I can also do things that help me to begin to exert control over those conditions. People who were very effective at exerting control over conditions were the ones who were doing TikTok videos, YouTube videos, and having 100 people kind of gather where you could do a happy hour virtually. Those are all great examples of coping. Stress and psychological distress 1 year after experience of non-COVID SARS virus. This is where this was a study looking at psychological distress and looking at what happens kind of 1 year later. I think a lot of people are feeling relief overall, but we still know that we still have a problem because we do not have complete immunity at this point, which means you can still get it. It's kind of like the flu. Just because you get the flu vaccine doesn't mean you can't get the flu. It means you have a less chance of getting the flu. More importantly, with COVID, if you get vaccinated, it has been shown to be 100% effective in preventing you from having serious symptoms that lead to hospitalization. And that's key, because you will do far better by not going into the hospital if at all possible. Meaning this, it's better to be in the community than to be in a system where you're dealing with constant infection rate. Research has also shown that high stress produces a cortisol response, which we've known for a good 50 years. And this is what's known as your stress hormone or your fight or flight hormone. What we know is that cortisol levels have been at an all-time high, and that what we also know is that cortisol levels that are at an all-time high for too long will then eventually lead to the immune system becoming compromised. So one of the things you have to keep in mind is that our initial response to stress is to have a response, a reaction, and to get you out of the stress. But unfortunately, as humans, we have a tendency to stay in our stress. And when we do that, what happens is we're causing cortisol to stay high for too long artificially. Well, what cortisol actually does is it begins to break down the cells and the lining of various organs in our body. So high cortisol over a long period of time is very destructive and can be extraordinarily dangerous. And in COVID, that was one of the issues that we were concerned about, is cortisol staying so high for so long that it could then lead to other acute problems. And one of those problems being a deficiency in the immune system, which is exactly what you don't want to see. Alcohol. People were actually coping with alcohol. And of course, that's something that's highly accessible. It's also something that kind of works in the short run. Alcohol naturally relaxes the system, and it also helps to relax your muscles and the central nervous system overall. It's also readily available. However, you have to be very careful because sometimes it's hard to regulate, obviously, the level of alcohol use. And so in moderation, probably not a problem. But if you're using it because you can't cope because your anxiety is too high, chances are you're going to be then drinking more alcohol than what would be reasonable, and in which case then you could do more harm than good. COVID-19 outbreak had a significant psychosocial impact on children and adolescents as well. The findings of current levels of anxiety and depression not only highlight the need to address emotional distress for children and adolescents during the pandemic, but also to provide researchers with scientific fundamentals to formulate targeted interventions based on significant influencing factors. One of the things that we found was that by just simply talking with kids about what's going on, it helps to reduce their stress. And remember, kids get their stress from parents and from adults. So if you're stressed, they're going to be stressed. If you maintain and manage your stress, then they're going to learn how to maintain and manage their stress as well. Some of the research that was done early on showed that when compared to non-COVID controlled patients, COVID patients who were in the hospital manifested higher levels of the following psychological conditions: depression, anxiety, and post-traumatic stress. They were all considered statistically significant. So again, the idea here is that COVID patients compared to non-COVID controls manifested higher levels of psychological findings. COVID-19 has also been shown to be related to acute stress disorder, which makes sense because acute stress disorder occurs within the first 3 to 30 days of an event that has the potential for causing a deadly outcome. And so, yes, the acute stress response is something that we would normally see. And if it persists longer than 30 days, then it becomes post-traumatic stress. Now let's talk about managing. So stress is perceived. And yes, that's going to sound a little bit funny, but it actually is. So in other words, what stresses me may not stress you, and vice versa. One of the examples of this is when we look at our soldiers who go across the globe to help to deal with military conflict. Not everybody comes back with post-traumatic stress disorder. And the reason being is because we know a couple of things. Those who have pre-existing anxiety responses that can be out of the ordinary are at higher risk of developing post-traumatic stress. You're also at higher risk of developing the acute stress response. And the acute stress response is then the lead into post-traumatic stress. So again, not everybody will experience COVID to the level that you may be experiencing it. If you use your cognitive functions or cognitive problem solving, then oftentimes you can change your perspective. This is a tool that I like to use. It's a cognitive triad, and basically what you're doing is you're looking at thoughts, feelings, and behaviors. First, what you do is you identify what you're thinking, what you actually feel, and then what you're doing at the time. Then what you do is decide, where do I want to intervene, or where do I want to cause something to change? You could do it with a thought, you could do it with a feeling or a behavior. I will tell you that 9 times out of 10, changing behavior tends to be easier than changing thoughts and feelings per se. Other techniques include deep breathing and relaxation. So deep breathing can be as simple as just simply counting in 1, 2, 3, and then counting out 1, 2, 3 as you exhale. It can become more complicated where you're doing deep breathing and you're pairing this with what's called a visual imagery, or you're pairing it with music or some other association that helps to make you feel calm. One of the things I like to do is what's called guided imagery, and this is where I get into my head and I create a scenario, like being at the beach or being in the mountains. In other words, being somewhere where I'm not normally, but makes me feel very calm and very soothing. Complex method is where you use deep breathing first to get you into a guided imagery, and then is to take the guided imagery and help to move you along and even get as high as meditation. So again, managing psychological stress, you have to be doing something about it. Think of this technique, and then you can think of making it more or less complex depending upon the way that you think or the way that you can do things. Exercise is also very good because it releases endorphins, and endorphins is your natural painkiller, but it also helps to stimulate serotonin. Serotonin is what helps us to feel better, helps us to feel more up, and to feel like a more steady mood. Exercise can be as little as 15 minutes a day, upwards to 1 to 2 hours at a time. And again, what we know that's optimal in healthy aging is to exercise about an hour a day. So again, you don't have to do this, go to Gold's Gym and work out 8 hours a day to be Mr. or Ms. Universe. It's more of doing something that's repetitive, things that's cardiovascular, things that's a little bit of weight training, and kind of putting all that together in about 15 minutes to 2 hours. But the idea during all this was that when people were working out, they actually felt better because they were releasing these endorphins. You can also stimulate your senses, sense of taste, sense of smell, touch, you name it, but you can stimulate your senses to the point where it helps as a distraction. So for example, what people were doing with alcohol is they were using the sense of taste. One of the things that I like is that sometimes when we're home is to burn a candle. So for example, vanilla, for whatever reason, is a smell that I like, or it's an odor that I like. It's very soothing, it's very calming. And so during high stress times, that's what you would want to potentially do. Tactile, those of us who have pets. I have a dog. She's very large. And so just feeling her fur helps to then make you feel more calm. Vision, this could be things like watching a movie or watching a favorite TV show, or getting on a Zoom call, as an example. And then audition, of course, is listening to your favorite thing, whether it's music, whether it's a podcast, or what have you. So in summary, COVID is a very unusual event that stirred many negative thoughts and feelings. The virus can cause many medical, neurologic, and psychological changes if contracted. It's a pandemic that we can get through, and we are in fact getting through, but please don't forget about the 3.7 million people who have passed away as a result of this deadly virus. We want to focus on things that we can control, not focusing on things that we cannot control. Think about the people that you love, support that you have, or the techniques that were discussed to get you through the pandemic. One of the things that I think it taught us is this: it's more important for us to be social beings than it is for us to have a lot of stuff. Because at the end of the day, you can have a lot of stuff and then you're still isolated. What's more important is that we have this outreach. One of the things that I found to be most profoundly impactful in healthcare is that we have connection with people now that we never used to use before. Focus on what you have. Focus on the thoughts of what makes sense to you, what's important to you. Anyone who's experienced something catastrophic knows that this is a great life lesson, because what it does is it puts things into perspective. Any of our survivors who are on the call, I'm sure that you've had a change in perspective as part of your survival and as part of your continuing to get up every day and do good things. So I'm going to stop here, and I'm going to see if there are any particular questions that I can answer. This is what I look like when I go to the beach. I know my teeth look a little rough, but not so bad. So I'm going to go ahead and open it up for questions. And what I'll do is, I guess I'll just go ahead and leave the PowerPoint up. But so I don't know, Doreen, did you want to feed me the questions, or is there a place that I can look?
Sure. I have one question here that says, in your opinion, doctor, should a brain injury have been a qualifier for access to a vaccine earlier? In Rhode Island, a brain injury wasn't a qualifier for early inoculation.
Yeah, it's a great question. The simple answer is don't really know. The complicated answer is certainly what we saw in the first 6 months of the data suggested that, yes, it probably should have qualified as being one of the disease processes that put you at higher risk, so that you would be in the earlier phase of getting your vaccination. Keep in mind, one of the things that happens with vaccinations when you have to do such a broad span of vaccination is you have to create arbitrary rules just so that way you can actually get it out to people and do it safely and following the guidelines. Remember that they were writing the guidelines at the same time that they were actually using the guidelines. So in retrospect, yep, I would agree that it would have been one of those conditions, but it is what it is.
Okay, I have another one here. Like, what should I have asked my doctor to look for if I had COVID and a brain injury? So this is from a survivor.
Yeah, it's a great question. So the first thing that I always look at, because this is actually just the, to put it simply, this is the theoretical underpinning of neurologic impairment. And that's this. Anytime you've had one brain injury, and you know how you'll get a set of deficits that occur early on, and then if the brain injury winds up being severe enough that then leads you to having residual impairments, then what happens in something like COVID is if it begins to have a neurologic impairment, it will first extend or it will accentuate your prior deficit. So it's in a sense, what it does is it brings back the old deficit. And then, for example, if you had loss of taste and smell at that time, it would tell you that the acute process is now working on the residual process. We see this a lot in concussion, where if I have one concussion, then I go through the process of recovery. Let's say 10 years later, I have a significant brain injury that now has led to being more moderate. Well, what will actually happen is it actually brings back some of the effects of the first concussion in the early stages until everything begins to then settle back down. So it's the same process.
Right. So it'll exacerbate that pre-existing condition then. Yeah.
That is correct.
Which makes sense. Yes.
Yep.
I'm not really sure if anyone else has a question to ask. They can put it in the chat section while I'm seeing if anyone wants to do that. I just want to remind people to make sure that they fill out the survey at the end or during the response email. I'm practicing wait time. Okay. Well, I thought it was very insightful and interesting, and a very, I mean, the topic is right here before us happening as time goes on. So I certainly thank you for your time. It was very informative, and I'm happy that we'll have it recorded so we can share it with more people after this. We thank everyone else for their participation. And if you want to visit our website at biari.org for more of our conference series offerings. And I thank you and have a great rest of your day. Thank you, Dr. Horn.
Thank you. Take
Certainly
care, everybody.
appreciate it.
Dr. Horn, very
Thank you.
interesting.
Mhm.